outreach, providing information and support while encouraging hope and faith, focusing specifically on severe and persistent mental illnesses as from a faith-based perspective. Today, what I wanted to talk about was the word endurance as it relates to a family member. To family members. Maybe about a few months ago, we had a conference and we brought some family members together. And one of them, when I asked about what's one of the most important things that as a family member or a family friend or a close family friend who's living with someone who has a severe and persistent mental illness, what are some of the things that they need to have or need to know? And the word that she started with was the word endurance. And as I started thinking about that, I thought about how important that word is, having the endurance. Because when we talk about the severe and persistent mental illnesses, that's something that you definitely have to have, not just for the family member, but for the person who's living with the illness. But for this broadcast, I wanted to talk to family members who are living with a loved one who has a severe and persistent mental illness. Now, before I go any further, as always, I'm reading off my computer some things that I wrote down so that I can make sure that I share. I want to start off by talking about the terms, some words. Mental illness, the term that refers collectively to all mental disorders, which are health conditions characterized by alterations in thinking, mood, or behavior. A mental disorder or mental illness is a diagnosable illness. Okay, that's the word. It's a diagnosable illness that influences a way a person thinks, feels, behaves, and relates to others in his surroundings. So a lot of times, I wanted to focus on that word diagnosable. For example, the word depression. A lot of people may say that, yes, I'm depressed, but what they mean is they are depressed or sad as it relates to a particular situation. That's a little different from a diagnosable disorder, major depressive disorder, or severe depression. Because when we're talking about a diagnosable disorder, we're saying that certain symptoms have been present for a certain period of time, and that we're saying that this illness impacts all aspects of a person's life. So, for example, again, we all get quote-unquote depressed or sad, but when we're talking about clinical depression, you can win the lottery for $1 million and still be sad. So again, when we're talking about clinical depression, it's not related necessarily to an outside environment or an outside event. An outside environment or event may trigger or add to it, but when we're talking about mental illnesses, we're talking about diagnosable illnesses that many of them have a biological basis. Now, the term severe and persistent mental illnesses. Severe and persistent mental illnesses are those that seriously limit an individual's ability to obtain employment, interact socially, or cope with everyday events. Severe and persistent mental illnesses last so long and are so severe that they impact all aspects of a person's life. So when we talk about severe and persistent mental illnesses, we're talking about illnesses such as schizophrenia and bipolar, severe depression. So again, mental illnesses, there are at least 20 categories of mental illnesses, and they're different within those categories. There are a whole bunch of different diagnoses. But when we talk about severe and persistent mental illnesses, we're talking about those illnesses that are so severe that they impact all aspects of an individual's life. Many times with severe and persistent mental illnesses, these disorders tend to start early in a person's life, which means because they start so early, that it can color the rest of their life. So for example, if a young person, a teenager, a young person, 20s, 18, 19, 20, starts experiencing symptoms and no one else really picks up on it or knows what's going on, that person will go through life struggling, right? They may not do well in school. They may not, they may go in and out of the prison system. They may start using drugs, and nobody knew that because they had a severe and persistent mental illness that was never treated properly. Now, for family members, having a family member with a severe mental illness is stressful, is a stressful activity, and it can be a prolonged process. People with serious mental illnesses are more likely to be unemployed, arrested, and or face inadequate housing compared to those without mental illness. And then I just want to say something here. People with SMI are more likely to be unemployed or arrested, face inadequate housing, be the victim of abuse, in comparison to those who are living with other mental illnesses. Again, we're talking about mental illnesses, severe and persistent mental illnesses. These are the people who are the most sick, or the most who need the most help among us. So when you're living with someone with an SMI, as a family member, it's important to understand that we're not talking about a 100-yard dash. We're talking about a relay. We're talking about something that's going to be up and down. It's an illness that you have to learn to live with. You have to learn to manage as a family member. You have to get good at understanding your loved one's symptoms. You have to get good at advocating for your loved one, unfortunately, sometimes. And it does take the endurance. Now, endurance, the fact, or power of enduring an unpleasant or difficult process or situation without giving way. The ability to sustain a prolonged stressful effort or activity. So let me kind of stay with this definition here for a minute. Okay? When we talk about endurance. And I got this from the Webster Dictionary, so. The fact or power of enduring a pleasant or unpleasant or difficult process or situation. As I said before, being a family member of a person with SMI, a severe mental illness, can be a difficult process. And some stages of the illness, your loved one may or may not realize that he or she is sick. They may refuse to get help. They may refuse to take their medications. They may start taking them and stop. They may become to the point where they want to be on their own, they want to be left alone, so it can be difficult. Sometimes you may be in your home as a family member and you can't sleep. You can't sleep because your family member is up walking the floor, or you come home and all your food is thrown out. Sometimes, there's a certain embarrassment sometimes for some people that go along with that, because you may come home and find that your loved one has thrown out all the food, or that your loved one has, gone out to the neighborhood and done something. So there's a lot that goes along with a severe and persistent mental illness. And I think a lot of times if you don't live with this reality, you think it's real easy. We had an unfortunate situation that was in the news. And I guess there are many unfortunate situations, but this is one where someone killed, with an SMI, killed a person. And I was looking at some of the posts, things that people say, and it was really negative towards the family members, towards the parents, as if the parents never try to get their family member help. I want you to know, it's hard. It's hard to get a grown person, an adult, help if they don't want it. And there are a lot of different phases. There are a lot of different, challenges that can come up with that. We do want to try it, but I just want you to know that it's not that easy. It's not easy to get guardianship, right? Unfortunately, sometimes you have to wait until your loved one hits rock bottom before you can do that. The laws are there for a purpose, and they're good laws. I'm not saying that, but sometimes they make it difficult for us to get our loved one help without jumping through a whole lot of hoops. And I'll talk more about that later. But I just want people to understand that when you come across a family member who has a loved one with a mental illness, a severe and persistent mental illness, you need to know that it's not easy. You need to know that they're human, right? That they've done many times what they know to do. They take their loved one to the hospital. Sometimes their loved one gets admitted. Sometimes they don't. They may stay for a little while, but then when they get out of the hospital, they're discharged back home, and they're fine for a while with their medications, and then after a period of time, they kind of stop taking it, or, et cetera, and it can go back and forth. So it's not that the family member didn't try, or they're not seeking hope for their loved one. Sometimes the process is a little harder than you think. And keep in mind that while the family members are trying to get help for their loved one and kind of, going here and going here and going here, they still have a life. They still have to take care of themselves, if they have other children, if they have to work. So all of those things, these things that they're trying to juggle and manage. So I think it's really important just to have a little respect, a little compassion, and understand how difficult that it is. Okay? Now, psychosis. One of the things when we talk about SMI, or one of the symptoms, SMIs tend to involve some degree of psychosis. SMI, severe mental illness. And you hear that a lot. People say, oh, that person's psychotic. or had some form of psychosis. What does that mean? Psychosis is a term used basically to describe a condition in which a person has lost contact with reality. So you can have psychosis, or a person could be psychotic, if you will, with several different illnesses. So psychotic being, when you use that term psychotic, that in itself is not necessarily, it's not a diagnosis, it's a symptom of a diagnosis. So when we talk about being out of touch with reality, we see that a lot in disorders such as schizophrenia. We see it in bipolar, psychotic depression, drug-induced psychosis, for example. Now, psychosis, we're looking at hallucinations, delusions, and I'll keep going further. But when we're talking about psychotic phases, they usually go through steps, right? There's usually a first step, second step, and third step. But when we're talking about the first step being pre-morbid phase, means there's no symptoms, but the person has a high risk factors. There's a prodromal phase. This is where you start to see changes in the emotions, motivation, thinking, perception, or behavior. This is where the person may start to act quote-unquote strange. This is where they may, well, at one point they used to eat with the family. Now they're taking off their food and they're just going in their room and they're being very suspicious. You see them being distrustful. You know, they start asking questions and maybe saying kind of odd things that you kind of look around like, what are you talking about? This is where the person's starting to become unwell. This is where, at first, it may be hard to pick up on, but usually the first time you have a loved one that has gone through a psychotic episode, it's easier for a family member sometimes to pick it up the second, third, and fourth time. But the first time, it can be a gradual thing, because a person can be going through these phases, these different steps, for a while before they get to what we call an acute psychotic phase. So when we talk about the prodromal phase, Prodromal, you start to see some changes, but sometimes the changes at first may not alarm you. You know, you might kind of look at the person's side eye a little bit, but you might not really kind of pick up on it. You may just kind of think, oh, they're just going through some changes, they're just going through something. But when we look at the acute psychotic phase, this is where we start to see the symptoms. Symptoms such as delusions. Delusions are false beliefs. This is where the person believes, right, that I am the president. They believe that somebody is putting something inside my brain. They believe that their thoughts are being broadcasted. So all of this type of stuff. They may have paranoid delusions and believe that others are trying to harm them, such as by cheating, harassing, poisoning, spying, or plotting on them, or the people they care about. When you talk about delusions, this is not a thing where you can kind of talk the person out of, because they actually really believe this. Okay, this is their fixed belief. This is their thought, and this is the difference between. Let's say I may say I believe, I don't know, that the moon is square. But if you show me, you know, the moon is not square, Arnetta, and you show me that the moon is round, is not square, then I'll go, oh, okay, all right. So I may have that kind of a weird belief, but when you point out evidence to me, I'm easy to say, okay, yeah, I get it. But when you're dealing with someone with a delusion, it's not going to happen that way. They're going to find reasons to hold on to their delusion. No, President Obama is my cousin, and he's not. But President Obama is my cousin. No, I am getting married to, I don't know, whoever, somebody famous in the news. So you're not going to be able to talk them out of it, okay? Next thing, when we're talking about a person in a psychotic episode, we're talking about hallucinations. Hallucinations has to do with the senses. I tell people to think of it like this. Delusions, M-I-N-D, mind, D, delusions. Delusions have to do with the thoughts. Hallucinations have to do with the senses. Most common, people talk about hearing voices. But a person can have a tactile hallucination where they feel like somebody's touching them. It can be olfactory hallucination for us to smell. I smell, you know, it's like somebody's coming through the room or whatever. It could be a taste. A feeling, like I said, it has to do with the senses. But keep in mind, hallucinations can be real, or perceived to be real, and it can be very scary. So again, you're not going to be able to talk a person out of this, because to them at that moment, their delusions and hallucinations are real. We were working with a gentleman one time, and he was convinced that he was married and that his wife lived at this particular address. And for some reason, some of his friends they went to the house to kind of show him, knocked on the door to show him, look, your wife doesn't live here. Actually, a man came to the door. He was like, no, get away from this door. But even with that, he wasn't convinced, because then he said, well, the man is probably, took my wife somewhere, and, blah, blah, blah. He still didn't believe it. When you're talking about hallucinations and delusions, please keep in mind these things are very serious to the individual, and you're not just going to be able to talk them out of it. The next other symptoms, when we talk about psychotic disorders, you start seeing changes in their emotion. You may see some depression, anxiety. Now, the depression and anxiety is related to the hallucinations and the delusions. Think about it. If you had all these thoughts going through your mind all of the time, and you felt like over and over and over again, you had these thoughts, it's hard to concentrate, right? So it's hard to concentrate. You do become your defenses are up. You do become suspicious, because you don't know who's out to get you. There's this exercise that sometimes that we do, and I would encourage you to do it if you wanted to, is to have yourself and two other people. You and your partner start reading, and then have that third person, as you guys are talking, to talk in your ear. And you'll find how difficult that is and how scary that is. And when that happens, it also makes you realize this is a little taste of what people go through when they're dealing with psychotic symptoms or hallucinations, for example, is that they're trying to concentrate, but they have these things going on in their mind. So with all of this stuff going on, it makes a person guarded, because they can't perceive reality. They can't trust reality. So they tend to kind of withdraw. They tend to want to be by themselves. That's not uncommon. So if you look at it, if you put yourself in the person's shoes for a minute, and you really just kind of think about what's going on, you can understand, hopefully, why our loved ones behave the way they behave, because they're afraid. They don't know what to trust. They hear you talking, but they also hear the other voice talking. Or they see you and they see the other things as well, and they just can't really gauge it. They think they can, it's you, and they're not really sure. So again, just kind of keep that in mind. Blunted or flat affect, that's like, for example, if you were to, win the lottery for $1 million, most people will at least smile. They may not smile, or they may say, oh, okay, just real blunted, flat affect. Difficulties with concentration or attention. It's hard for them to concentrate. They kind of feel like that other people around them are acting different. That they may feel like they're not a part of this world, that their body is partly in the world, not in the world. You start seeing sleep disturbances, social isolation or withdrawal, reduced ability to carry out work in social roles. So where they may used to be more social in one area, you see them start to withdraw. You see them start wanting to be alone. That kind of behavior. When a loved one is in a psychotic state, it is important to get them help. But keep in mind that when they're in that particular state, especially the acute phase, because many times, unfortunately, the first time, that's when we start getting help. Because when they're going through the different phases, we may not see it, or when I say see it, we see it, but we may not really know what it is, or we may think that the person will get better, or they're just going through a phase, and we ignore it until things start to intensify. I tell people relapse, for example, doesn't happen overnight. When we talk about psychiatric relapse, there are usually signs and symptoms that were there, but it's just that we didn't pay attention to it. But when we talk about psychosis and being in a psychotic state, the main thing is you have to get the person help. Okay? Help in the form of medication is out there. For the family member, getting help can be a challenge. It can be hard to get help depending on where you live. But living with your loved one while they're going through the psychotic stage can be draining. Like I said, you may not be able to sleep. You may get a whole bunch of complaints from neighbors. I have a friend of mine, when their loved one was in that psychotic state, they would go walk around, go down to the washroom in the building and just kind of open and close the washer and dryers and move things around. And of course, they would get complaints from the neighbors. I know other situations where family members had to endure, they're trying to sleep, their loved one is sneaking out and just running up and down the building or running up and down the block. So there are a lot of different things. So endurance is the key. You have to, unfortunately, family member, loved one, you may be the only one that will be able to advocate for your family member, but keep in mind, know that it's a challenge. You have to know that it's a challenge. Now I'm going to talk about some of the feelings that a person may feel, but before I do that, let me talk about getting help for your loved one. Okay? We kind of have a little booklet on our website where we talk about this, but I wanted to talk about it here. Getting help for someone else. Depending on where you live, symptoms, and previous history, you may choose to contact your local crisis team or 911. Every jurisdiction doesn't have a crisis team. Okay? If you don't have one, a crisis team, many public mental health agencies, state agencies, they have crisis teams, right? Where you can call a number and say, hey, my loved one is in a psychiatric crisis, what do I do? And that crisis team will come out or they'll talk you through the process. But every state doesn't have one. Now, the difference between a crisis team and a police, crisis teams usually have several people on the team. TEAM, it's a team. They may have maybe a nurse, they may have a LICSW, clinical social worker, they may have a therapist, they may have, it varies, but they're all mental health professionals. But what they are not are police officers, and that's the big difference. So when you have to decide who should I call, let's just say you're in a jurisdiction and you do have both, a crisis team and 911. You have to think about the situation. If your loved one is actively harming themselves or if they're actively threatening themselves, then you might have to call the police. Now, no one likes to call the police because a lot of things can go wrong, but when you call, you can ask and say, okay, and say, my loved one is having a medical emergency. Do you have a crisis officer, a police officer on duty that can work with people who have mental illness? Many police jurisdictions do have that. They do have police officers who've gone through the training in order to work with people with severe and persistent mental illnesses, but not all of them do. So, but you can ask. But the big difference between a crisis team and the police is that a crisis team cannot physically make a person go to the hospital or take a person anywhere against their will, and they can't if there's a dangerous situation. The crisis team, they're going to come, and if they perceive that it's a dangerous situation, they're going to fill out paperwork and they're going to call the police. So you have to think about, is this a situation where I could get hurt or my loved one could get hurt, an imminent situation? Then you may have to call the police. Again, nobody likes calling the police on their loved one, but I can tell you from experience that when you do have to call the police and the police come, many times your loved one, no matter what happens during that exchange, when your loved one gets better, they're not mad with you. And I think that's the thing. We feel, oh, they're going to be mad with me. I don't want to do it. It makes them think they're a criminal. No, you have to get your loved one help. I always tell people, would you have this much hesitation? Let's say you came into a home and your loved one was bleeding, or somebody's bleeding all over the place and they couldn't breathe. No, you pick up the phone and call 911 and get some help. So when you think about a person in a psychotic episode or a psychotic state, they're bleeding, but it's just you can't see the blood. They're bleeding emotionally. They're bleeding psychologically. No one would walk around or live in their own feces, right? So why would you let your loved one do that? No one would walk around, sometimes when a person is in a psychotic state, their mind is really ruling, if you will. So you may see them walking around, it could be 100 degrees outside, and they have all these clothes on. No one, quote unquote, in their right mind will want to live like that. You may, or when it's cold, right? In some jurisdictions, when it's really chilly outside, the order will go out. The police will have to bring a person inside because we don't want them out on out in the street because they can freeze to death. But some of them won't go. They won't get help because they're leading with their mind. So for me, when you think about when people make all these excuses about not wanting to get a person help, we're talking about mental illnesses, we're talking about brain illnesses. The brain gets sick just like any other organ. So why would you not help someone who has a brain illness? Why would you try to hide? Why would you try, well, I don't want to say anything and wait till the person gets so bad until they hurt themselves or they hurt you or they hurt someone else? You could have gotten them help or at least trying much earlier, okay? So it's important to do that. So again, a crisis team and police. But let's just say you call the crisis team, okay? The crisis team, what they should do, they'll come out or call or counsel you over the phone, tell you what to do. Let's just say they come out. They'll talk to your loved one. If your loved one is already connected with services, they'll try to get your loved one reconnected. So, for example, if they had a psychotic episode or they're having some mental health challenges on a Thursday night, they may, call, okay, your loved one's connected. They may call the doctor for you and say, hey, you're Joe Blow. We have one of your patients here. He's not doing well. Can he come in tomorrow to see you as an emergency walk-in? So they may do that kind of stuff. But keep in mind, a lot of places throughout the United States are not as fortunate. I always say in cities, you tend to see more resources, right? More mental health resources. But it's not the case in rural areas or out in the country. That's not the case all the time. You may only have one psychiatrist, and in order to get to that one psychiatrist, you may have to drive 4 or 5 hours. The only help that your loved one may be able to get is through the hospital, and the hospital itself may be a couple hours away. So again, when I talk about getting help for someone else, it will vary depending on where you are. If you're in Baltimore, Washington, D.C., yeah, you can pick up a phone and call a crisis team. You can't do that necessarily maybe if you're out in Idaho and you're living on a 50-mile ranch and the nearest hospital, like I said, is several hours away. So it just kind of varies. But the crisis team, they will come out or talk to you, and they can help diffuse the situation. They can help deal with your anxiety, your stress. They can kind of walk you through it. If they come out and they feel, hey, there's something that's going on, and your loved one does have to go to the hospital, it can go different ways at this point. They may be able to encourage your loved one to go to the hospital voluntarily, which is always great, or they may have to do and the word changes depending on where you live, but just fill out paperwork to do an involuntary commitment. Let's just call it that, because it's called different places, different things in different places. They may fill that out. Now, again, this is where it gets tricky, because they don't many times have the authority to make a person go anywhere. So they're still going to have to call the police. But if it's iffy, many times the police, they will come out, and if they see a crisis team is already involved, they may be more inclined to take the person because they know, okay, someone else has assessed the case. We have a mental health professional on the scene. Okay, we'll take it. But the police may or may not. And again, I'm just kind of throwing a lot of different variables out to do two things. One, to let those of you who have never gone through the process before or have never dealt with someone with an SMI to understand it's not as easy as you think, that a lot of things can happen. In the real world, you will call the police, call the crisis team, they will come out, they assess your loved one, see what you see, and take them to the hospital. Your loved one gets to the hospital, the doctor will agree with you and say, yep, we need to commit the person, your loved one. They are committed for a while, they come out of the hospital, they're doing great, and life is peachy cream. That's not how it happens all the time. A lot of different things can go wrong or not as planned, and I kind of throw all of these out so you can kind of think about it and don't be surprised if it happens, because the crisis team may come out or the police may come out and your loved one may do a 180. Your loved one, especially if they've been to the hospital before and they don't want to go back, by the time you call, whether it's the crisis team or the police, by the time they get there, your loved one has changed, right? Before they were engaging in all these types of different behaviors, and when the police show up, they're sitting down calm, they're relaxed. Crisis team comes, they're talking to them, oh yeah, sure, no problem, and you know, in a logical way, and you're sitting there looking like, what the heck just happened? Many times that happens. Family members, we talk about that a lot, and sometimes we kind of smile about it. I'm like, wait a minute ago that wasn't the case. But call anyway if you feel uncomfortable. Get the help. You don't have to deal with this on your own. If there's not a crisis team in your area, I'm going to give you a 1-800 number that you can call. They can at least walk you through it. They can at least help you feel better about what you're dealing with and the decisions that you have to make. Because many times as a family member, you feel helpless. You just don't know what to do. Sometimes you just need to have someone to talk to and to talk things through to get different advice. Sometimes you have to talk it through to realize that you're not alone, right? Severe and persistent mental illnesses are not as common as some of the other disorders, but they are common enough that there are plenty of loved ones or family members who are going through the same thing that you may go through or going through at the moment. So again, let's just say, they come out, they see what you see, and you're now at the hospital. Okay? Now, and I'm going through my said this. And I just want to, let me kind of go back to this because this is so important. Just because you call the police or crisis team and request that they take your loved one to a hospital, there is no guarantee that they will. In general, the police take removing a person from their home and escort them to the hospital against their will very seriously. Everybody does. Especially if they arrive on the scene and don't see the signs that you saw or your loved one appears fine. Your loved one will say, I'm fine. I've had cases where the police have gone out, and the crisis team as well, and the police, after talking to your loved one, the person, they'll take their medication. Oh yeah, I'll take it right in front of the police. They'll take their medications and they'll calm. The police are not going to take them to anywhere because the person is calm. Now, unfortunately, after you do that, you might be so upset that, and many times this happens as a family member, you're just so tired. You've done all of this, and then your loved one is still sitting in your living room, and you're just exhausted. That happens as well. Unfortunately, just because you feel that your loved one should be taken to the hospital because they are not taking their medications or whatever, that's not the case. Your loved one has a right to refuse their medications and to refuse to see their outpatient therapist or to get help. They have their right. That's their right to say, I don't want to go, I don't want treatment. The question you have to ask, be prepared if you don't really get anything out of what I'm saying, the question you have to ask yourself is, how are the signs and symptoms experienced by your loved one negatively impacting them, and then be prepared to make a case. That's the thing is you can't just say, well, take him or get to the hospital and say he's not taking his medications. A lot can happen. Sometimes that can work, but if it's a Friday night and everything is busy, your loved one may not do anything. They may just give them enough medications and send them home. So the question you need to always ask is, why are you calling the crisis team? Right? Many times family members will call the crisis team because they're frustrated. And there's nothing wrong with that. That's what they're there for, right? But just because you're frustrated doesn't mean that when they come out again, that's a reason for them to take your loved one, right? That your frustration, even though I may think it's valid, is not enough to hold a person into a hospital, right? That you have to be able to say why. Because when you're taking a person, a loved one, to the hospital against their will, there's things that happen, right? That doesn't mean they're admitted. I'm going to walk through the steps here. But when they get to the hospital, the doctor there has to, he or she will read what you said, what the crisis team said, what the police said, all of those reports, and he or she will has to make the determination whether to keep the person or not keep the person. And usually, if they decide to keep the person, it's not going to be that long, or may not be that long. So it just kind of depends. So when you get to that your loved one gets to the hospital, if at all possible, you should be there. You should follow in the car. If you don't, in a cab, Uber, or whatever. If you can't, you need to be on the phone. You got to be involved. You can't just, have the police or crisis team take them to the hospital, and you go, phew, finally I'm going to get some rest. It may not. A few hours later, you look around, your loved one is back home. You have to go to the hospital. Again, we're talking about endurance. To go to the hospital and explain to the doctor what is going on. What is going on, but always think how they're thinking, right? It's just because they're not taking their medication, so what? You have to be able to say, make the case that as a result of not taking the medication, like I said before, use the example, someone had a loved one who was going down into the washing area in the apartment building and just opening and closing and doing this type of stuff. You have to be able to say, hey doc, this is what my loved one is doing, and as a result of that, my loved one is getting threats. People are threatening to beat him up. People are threatening to or harassing him. He can get really hurt, right? So as a result of his behaviors and what he's doing, he can get hurt. Let me go back to this phrase people like to use, is he a danger to himself or others? That can't, a lot of times people use that so specifically, or does that mean they're suicidal or homicidal? You have to think broader than that, and you have to be able to make the case. So, for example, if your loved one is taking other medications, and as a result of his psychosis, he no longer wants to take those medications, the doctor needs to know that. Okay, my loved one is a diabetic, he hasn't been taking his medications. If he doesn't take his medications, he could die. Right? As a result of him thinking that there's poison in his food, my loved one has lost 50 pounds in a week. As a result of him thinking that somebody's out to get him, he is walking up and down the neighborhood with no clothes on, or in his 5 degrees down outside or whatever. You can't just come there with just your frustrations, is what I'm saying, because the doctor also have their own frustration, right? You may only get to a place, especially depending on the night it is, they may only have 10 beds and they got 50 people waiting. So they have to decide who gets admitted, who doesn't get admitted. You have insurance issues to think about. You have to think about, not just the bed, insurance issues. They have to look at, well, does your loved one already have a outpatient therapist or outpatient psychiatrist? Well, if they do, what medications are they on? They may kind of take a look at that, make some changes to the medications, let your loved one stay maybe for a few hours or overnight in the ER, and then they send him or her home. So again, endurance. That's a lot. If you can go to that hospital, or you need to do that. Don't just assume, and don't just tell the doctor, that you're frustrated. You need to be able to explain why. Whoever you're talking to, you always think about, ask yourself, what are the signs and symptoms that you're seeing, and how are these signs and symptoms negatively impacting your loved one, and then be prepared to make a case. Okay? Oh, let me keep going. I'm sorry. I think I'm talking. If the police agree with you, or crisis team, they take your loved one, please know that if the police come, they're going to handcuff your loved one. And I always like pointing this out to people because it can be scary, right? It's scary when this has happened for the first time and you don't know. Your loved one will be handcuffed. And, I was involved in a situation where we had to get a person to the hospital, and she was small little lady, maybe like in her 70s, but she wasn't hurt to fly. She was just needed to go. And when she came, they had to put handcuffs on her, and we're like, why are you going to handcuff the lady, right? But keep in mind, the police don't know your loved one. That was the first time they saw her, so the handcuffing is for their protection as well as hers, because let's just say they didn't handcuff her. She's in the back of the police car. I don't know. She might start acting erratic and want to start punching things or whatever. So they will handcuff. But keep in mind, they're not saying that she's a criminal or your loved one is a criminal. It's about protection. So I always kind of tell people that. Also keep in mind that let's say you do have to call the police. Don't call the police unless you really need to call the police. As much as possible, you can try to diffuse the situation. If you can get your loved one to go to the hospital along with you, as far as you take them, as far as an voluntary admission, that's great. But keep in mind, when the police come, they may not be as gentle as you are. But also think about this. You're calling the police because whatever you've tried, the strategies that you've tried are no longer working. And you need to get your loved one help. So don't, you can't necessarily dictate to the police how they do certain things. Because even if it's a police officer who's trained in mental health intervention, at some point, they're going to have to kind of be a police officer. And I shared this story before. Another situation where we had to, in this case, call the police and get someone admitted to the hospital. And it was the grandmother that was there, and myself and a couple of other people. And a real police officer came in, was real nice, was, kind of talking and, kind of going through the steps. Took a lot of time with the person. But the problem was the gentleman would not take his hands out of his pocket. And when they called us, we couldn't say whether he had a weapon or don't, because they asked you, we don't know. But he wouldn't take his hands out of his pockets. And the police officer kept kind of talking to him, and he made a move. And the police officer, along with the partner, had to take him down to the floor. And it was very stressful for the grandmother because she couldn't understand that. Well, come to find out, he had one of these real long nails in his pocket. I don't know what he'd done with the, one of those real long nails. What he'd done with the nail, I don't know. This was a person who had previously tried to take his eyes out. So who knows? My point being is that, the police officer was trained, but at some point, the police officer had to be a police officer because it's about safety. So all of these things can happen. Okay. So I talk about handcuffing. Let's say now your person is at the hospital. They take him. Another thing too, keep in mind that sometimes the police will ask you to go, or if there's someone can go, because many times, depending on the jurisdiction, police officers kind of really don't like not just doing that, because sometimes they have to wait. And then if they have to wait a long time, if they get to the emergency room, if the emergency room is full, I used to think that if police comes to the emergency room, they get first in the line. But I don't think that's always the case, I'm told. So they get there, they have to wait with the person for a little while, and many times they don't like doing that. So keep that in mind. Let's say you're at the hospital now. Finally, once at the hospital, the decision to involuntarily commit your loved one is up to the doctor. Again, like I said before, just like the police, doctors don't make this decision lightly. While almost all states allow police and clinicians to initiate short-term commitments lasting up to 72 hours to handle imminent emergencies, there are legal statutes that must be met to hold a person against their will, right? So when your loved one comes in, if the doctor decides, okay, we'll hold him or her for 72 hours, then after that 72 hours, there are things that have to happen. And I'll put the link on my website because it varies with the state, but there's a whole lot that goes along with that, trying to keep a person. I mean, they get a lawyer, the hospital gets a lawyer. It can be a prolonged process. So again, doctors think about all of that, when your loved one comes in. Also keep in mind, the goal is not to admit people to the hospital. The goal is to stabilize a person, and if they can get better out in the community, to keep them out in the community. The goal is, if they have a doctor, to get the person stable and to get them back out into the community and home as possible. So while that may not be, that's a doctor's goal, that may not be your goal. So that's why you guys have to kind of talk about it. Now, let me keep going. What you may experience at the hospital. And again, your experience at the hospital will vary depending on a lot of things. Your insurance, the hospital, time of day, your symptoms, etc. Whether you go into the hospital voluntarily or involuntarily. If you're on medications or not on medications, if you already have a doctor, it just kind of varies. But just because, like I said, you make it to the hospital doesn't mean they're going to keep you. Let me go through a few things. While at the hospital, you may be seen at the emergency room first, unless previous arrangements were made. If your loved one has a therapist or a psychiatrist, it may be a good idea. First of all, if your loved one has a psychiatrist, you should, as a family member, loved one, you need to know who that psychiatrist is. You should know what medications your loved one is on, is really helpful, and you should have a consent to be able to talk to your hospital, to your loved one's psychiatrist. Because sometimes you can call your psychiatrist, your loved one's psychiatrist, and say, this is what I'm noticing, what's going on. And the psychiatrist can say, okay, bring him in, not bring him in, take him to the hospital. Because sometimes if the psychiatrist has arranged the admission, things can go much smoother. So that's another thing to remember. You may have a long wait, but don't let that discourage you, especially if you're going on a Friday night or walking in. You're going to be asked a whole bunch of questions. Your loved one, you're going to may have to repeat yourself, but just know that's part of the process. The first doctor you see may or may not be the psychiatrist. Many times the psychiatrist is not just hanging around the emergency room. He or she has to be called, right? So you may have to wait for an evaluation. And again, like I said before, even if you feel that you or your loved one is experiencing a mental health event that requires admission into a hospital, the doctor at the hospital may not feel the same way. Keep that in mind. So be prepared to make a case. And unfortunately, sometimes you do have to make a case. Just saying my loved one has schizophrenia is not enough, or may not be enough, to get them admitted into the hospital. Like I said before, if there are very few beds, if the doctor thinks that your loved one can be stabilized with a medication change, sent back home, they have insurance issues, or your loved one suddenly gets better, and again, like I said, they once they realize the reality of it, you'll be surprised how people suddenly no longer psychotic, and they're home. They're back home, and I've seen it so many times. I mean, the person goes to the hospital, and you finally think you're going to get a good night's sleep, and you may sleep for a few hours, and then you look up and they're back. And some hospitals now, if you don't come pick them up, because they know you probably won't come pick them up if you really want them to stay, they will put them in a cab. And I've had experiences, and you can't be afraid to push back. And unfortunately, I hate to say it like that, but sometimes you do. I've had to do that. Hospitals want to discharge somebody. Look, they just got here, okay? They just got here like on a Thursday night. It's Friday. You want to discharge them over the weekend. Can you at least keep them through Monday? No. We need this. Well, no. And I hate to say this, but sometimes you kind of try to play hardball. Well, no, I'm not going to come pick them up. I'm thinking if I don't pick them up, the hospital will okay, we'll keep them until Monday. Nope. I've seen cases where, I've said, no, we're not going to pick the person up because I don't think this is a safe discharge during the weekend. And guess what? The hospital, all of a sudden, they find money, a cab voucher money, and your loved one is in the cab and they're back. So, but you got to be prepared to speak up. You have to, if you feel that admission is needed, then say so. Be prepared to speak to why you are seeking help. Describe the symptoms you are experiencing, and like I said before, and explain how those symptoms are negatively impacting. You have to be able to talk about that. Don't worry about using the right psychological terms, because many times, someone may come in and say, well, my loved one has experienced a psychotic episode and a delusion and hallucinations. And from the way you're using it, we may realize that you probably don't really know what that means, but just say what it is that you're seeing. That's more helpful to a doctor many times than you coming in trying to use the jargon. Because some family members, what you try to do is you think by using the jargon, they're just going to kind of encourage and motivate the doctor to admit the person. By you coming in and saying the person is suicidal or homicidal, that should be an automatic admit. No, because the doctor is going to assess the person as well. And once they assess the person and they determine that that's not the case, or the person says no, or the person says, yeah, I said it at the time, but I was upset, I don't feel like now, I don't have any weapons, I want to go to school in the morning, etc., etc., and then now you're stuck. just be honest with what you're seeing. Many times when you go there, the doctor sometimes can help you or kind of help you with resources. But you got to speak up. Another thing too, and again, sometimes the doctors are busy in the emergency room, or they're busy, or they're doing a lot of stuff. You have to say stop. You have to speak up. You have to advocate. You have to say what you're seeing, and you have to kind of be a little, sometimes persistent about it. And this is not always the case, but I don't want you to, again, I've been doing this for a while and I know that things don't go as smooth as you may think they should go. Especially if your loved one is belligerent or doesn't want to stay in the hospital. They can come up with all kind of stuff to say that they don't want, I don't want to stay. And because they don't want to stay, they all of a sudden, like I said, they get better. So again, just something to keep in mind. I'm talking about endurance, but I wanted to go through this again. Unfortunately, many people feel that the only way for them or someone that they love to be admitted in the hospital is to wait until they get really bad or say that they are suicidal. Sometimes that may be the case depending on where you live, but there are other ways. Like I said before, if your loved one has a chronic health condition, all the symptoms associated with a psychiatric illness, such as not taking their medications, keeping them from recognizing the need to take their other medications, or the symptoms of their mental illness causing disruptions to the neighbors or strangers in the area to the point that if not managed could cause harm to your loved one. Is your loved one losing sleep? Are they losing weight? Are they not eating? And if they are, how is this impacting them? They've lost 20 pounds. If you guys already have a psychiatrist, stay in contact with a psychiatrist. You have a crisis team. Get to know the resources in your area. All this type of stuff. So again, and then if your loved one is admitted, they'll go through a medical workup. They'll have a treatment team meeting. If they are admitted, again, endurance. You need to be there at the treatment team meeting. You need to talk with them, because many times, depending on the hospital, if a person, loved one gets in there that night, okay, they're admitted that night. The next morning they're going to have the treatment team meeting. They have residents. They have the attending there that will come. They may do their rounds. That attending may decide that the person, we're not going to keep it no longer than 2-3 days. And your mind, again, you want them to stay longer. You need to be able to say that. Sometimes they may have a treatment team meeting and you don't even know they had the treatment team meeting, which is why you need to be there, right? You need to ask questions. They need to know that your loved one has a loved one who is going to ask questions. That your loved one has a loved one that's involved with their treatment. Okay? And I think that's really important. I can't say that again. If there's a team meeting, you want to be at the team meeting. Your input is valuable to help ensure that the treatment team is focusing on the right goals. Your loved one may not be able to articulate it clearly, or may not want to articulate it clearly. Well, why are you here? Well, I'm here because, I don't know why I'm here. They just said I wasn't taking my medications, but I started taking them and they still admitted me. Most of the times, everybody understands that if you're admitted, there's a reason why you're admitted, but I'm just saying it's good with the doctors on the treatment team or in the hospital can get more feedback from family members or people who are there, because all they know the first time they see your loved one is they're reading a paper, they're seeing your loved one, they're talking to him or her, and it just depends. Because if your loved one got a cocktail the night before with a group of medications, let's say the night before, they may be groggy when they see the attending in the morning. By the end of the day, they'll see them the next, and they're much better. But you may know, no, they're not really that better. You have to be able to speak up. Again, I'm just kind of harping on this because it's so important. You may feel that your loved one should be in the hospital for longer than 2 days. If this is the case, again, you got to be able to say so. What many times, unfortunately, what happens, some loved ones, you get a sense of relief when your loved one is in the hospital, and then when they get released earlier, you feel like you don't have an option. You feel like, oh gosh, I've done all I can do, I can't do anything else. No, you have to continue to be diligent, and you have to continue to endure. Many times, inpatient hospitals, like I said, it's not like it was, what was that movie? That was a movie that came out, One Flew Over the Cuckoo's Nest, where a person would go into the hospital and they would stay there like forever. That's not the case now. We have very few, throughout the United States, very few hospitals, acute care, well not acute care, chronic care hospitals where a person stays years and years and years. We still have them, that does happen, but not to the same extent that it did a long time ago. We have a lot of newer psychotic medications, psychotropic medications, and a person that work faster, work better, so people can be stabilized and sent home much faster. But here's the thing, you live with your family member, and you know the challenges that you and your loved one will face once he or she is discharged. That's why you need to speak up. Share those challenges. So even if the doctor may say, well, no, there's no reason to keep him or her here for a month or for a few weeks, a week is fine, you can at least say, okay, let's talk about the environment where they live. The doctor may or may not realize that your loved one, that there's no psychiatrist in the area, or that it's hard to get a psychiatrist. When you're in the hospital, I always say it's an opportunity to start again, or it's an opportunity to start again. Because when you're in the hospital, you can get resources. You have a case manager, a social worker, somebody that can help with discharge planning, but you have to be diligent. You have to reach out to that person sometimes. Many times they'll reach out to you, but I'm just saying if they don't, you need to do that. Because again, you are the person that's going to be living with your loved one once they get out of the hospital. So you may need to talk to whoever is working with the discharge, the doctor, discharge planner, and kind of say, advocate for your loved one. Sometimes if they give you a script, you might want to say, and you don't have a way to fill the prescription, can I fill it here at the hospital, right? You give me samples, right? Your next appointment, your loved one's next appointment, they're out of the hospital on the 15th of January, and the earliest appointment they can see is appointment with a psychiatrist on the outside is the 15th of March. That's a few months, right? You might need to advocate. You may need to let the doctors, everybody in the hospital know, hey, can I have some samples to kind of hold us over until we see the doctor? Or can you write a refill? Can you give us enough? Again, people are busy. Sometimes they don't think about these things. And if you don't say anything, sometimes things fall through the cracks. Because if your loved one is in the hospital, and they're stabilized, that is an opportunity to begin again. It's an opportunity now. Hopefully they're in a better place where you and your loved one can really take the outpatient treatment part of it real seriously. A lot of times people come out of the hospital, they have a false sense of relief because severe and persistent mental illness, we're talking about cycles, right? Up and down. So you have this false sense of relief because the person's doing well now. It doesn't dawn upon you, or you don't really think, for some people, they're doing well because they have medications in their system. And unlike some medications, psychotropic medications don't necessarily work like that, where if you miss a dose, the person is automatically going to go into some kind of convulsion or something like that. It may take a little while for the medications to get out of their system before you realize that they haven't been taking it, or that they're not doing well, or they're starting to become unwell. That's not what you want. When a person gets out of the hospital, you want to make sure your loved one has their medications. You want to make sure they have a follow-up appointment, and you want to do what you can to make sure that they go. This is an opportunity to talk to your loved one. Okay, what happened? Okay, get their understanding about what happened. Get them to talk about what they were feeling, what they were thinking. Ask them how you can help them if this happens again. Work with them, you and them, to kind of develop a plan and say, okay, what should we do if this happens again? Should we call? Who should we call? You want to talk to them, okay? Talk to them about their triggers. Talk to them about some of their signs, relapse symptoms and signs. So that way you guys can form some type of relationship, you and your loved one. Again, people have a false sense of security. The person is out of the hospital and they're doing a little better. You feel great until the next time. The whole idea, we don't want it to be a next time. We want you to make sure that you follow through. Again, we talk about endurance. You may have to push your loved one, but at this point, they're no longer in the active phase or the active phase of their psychosis or out of touch with reality, so you can kind of talk to them and kind of process things a little better. If they go to the to their outpatient doctor, try to go with them. Right, try to go with them. That's the time. Then when they're feeling pretty good and things are better, where you can get the release of information signed. Go in and talk with them. You want to allow them to have their private time with the team as well. But you want to go in. You want to make sure they know. I'm Mrs. So and so. This is my son. This is my husband. This is my wife, my brother, etc. This is my number. If you can call me, what is your number, doctor? What's the number here? I have the release because I would like to call. I would like to check in. I like to see how my brother is doing once a month, twice a month, or whatever the case is. You need to do that because the more diligent you are doing those phases, and you ensure that they have a psychiatrist, that they meet with their treatment team. When your loved one starts to relapse or you start seeing changes, you have somebody you can reach out to. You have somebody you can call. Because the whole idea, when you start seeing the relapse, you want to try to catch it before it gets to the point where your loved one has to go to the hospital or before the relapse turns into a full-blown relapse. Stress. When we talk about severe and persistent mental illnesses, one of the triggers is stress. But don't think of stress like you might think of. Anything can be stressful, right? It could be trying to learn how to catch the bus. It could be learning how to cook for the first time. So stress is really important. Change are things that can be triggers for a person with a severe and persistent mental illness. So you have to pay attention to all of this. You need to know what the treatment plan is. And I tell people, if you see the treatment plan, they're supposed to be meeting with their therapist once a month, and they're not doing that, you need to find out why. Because somebody dropped the ball. Because keep in mind, the whole idea, you don't want to have to call 911 again. You don't want to have to call a crisis team again. You don't want them to have to go back into the hospital. Again, if they do, then they do, but you want to try not to have that happen. So again, where am I? Okay, I'm back at the hospital and you're about to be discharged. You need to let your team know kind of what's going on. And like I said before, it's important to follow up, but a lot of times many people don't. Follow up with your outpatient appointments. As a loved one, you want to get help. One of the scriptures that I wanted to read, there have no temptation taken you, but such as is common to man. But God is faithful, who will not suffer you to be tempted above that you are able, but will with the temptation also make a way to escape, that you may be able to bear it. 1 Corinthians 10:13. And Proverbs 11:14 says, but in the multitude of counselors there is safety. Attempting to live your life in a vacuum without the assistance or help of anyone else is short-sighted and is unrealistic. God didn't create anybody to live in isolation or alone. And I'm talking to you family members. There are people out there who can understand and who can walk you through this process. This is, in fact, going back to the word endurance, living with your loved one during a psychotic stage or a severe and persistent mental illness can be draining, it can be tiring, it can invoke all types of feelings. Don't let pride get in. Oh, I don't want anybody to know. Don't try to be a hero or go this alone. You need help. You need somebody to talk to. Your loved one is fine, but you need someone to share your feelings with. Some common feelings is resentment. And then you feel guilty about feeling resentful. But being resentful, and I went to the dictionaries, I wanted to share this. A feeling of indignant displeasure or persistent ill will as something regarded as a wrong, insult, or injury. As a family member, it's not uncommon to have some resentment towards your loved one. To feel resentful about the fact that, okay, you're not taking your medication, you're not listening. It's not uncommon to get angry. You're human. You don't have to kind of walk around like you're some super saint or you never get angry. You're going to get angry during this process. You're going to get frustrated. You're going to feel like, okay, you're at your wit's end. This is the second time, third time we're going to the hospital. I've told him to take his medications. I don't know what to do. He doesn't want to listen. You're going to be upset. You're going to be frustrated. You're going to, maybe curse sometime. You're going to say things that you wish you hadn't have said. That it's okay. You're human. This is a process. As I said, this is not a 100-yard dash. This is a marathon. And you can't beat yourself up for being human. You just got to realize, okay, I need help, right? Resentful, and then when people start feeling resentment, like I said, they start feeling guilty. Well, he's sick. I shouldn't feel this way. Well, but you do. So that means you need somebody to talk to. That person could be a therapist, or it could be a friend or family member, and just somebody that you can trust to say, I hate the fact that I have to take over my job to go to the hospital. I'm on the verge of trying to make partner, and I have to deal with this. It's okay to say that. But the problem is people don't say it, and then it bottles up, and it kind of shows up in different ways. Guilt. Feelings of deserving blame, especially for imagined offenses or from a sense of inadequacy. Some family members feel guilty. They feel guilty about, oh my God, this is something my loved one did, and I'm dealing with all this guilt. Keep in mind that it's not your responsibility to feel guilty. It's not anybody's responsibility to feel guilty. Sometimes people just get sick. The brain gets sick. The thing is, you have to learn how to live with this new reality. And learning to live with this new reality many times may involve you getting help and talking to other people. So don't carry that guilt around. There's a sense of being lonely, being without company, because for some family members, they feel like, it's their responsibility to protect their loved one from the world, and the world from their loved one. They know something is going on. They're on edge all the time about what may happen. They don't want to talk to other people about what's going on. They keep everything inside. And again, you don't have to do that. There are organizations that can help you. You can log on to our website at igbatt.com, go to our mental health page, and then we have a link there about support, because there are many organizations that can help you as a family member work through what you need to work through. But the guilt is common, as I said, being resentful, lonely, being angry, and at some point you just get tired. Sometimes you just get tired. And sometimes when you get tired, that's when you're just like, what, I just can't anymore. This is like the third time he or she is not taking their medications, and I don't know what else to do. When you get to that point, that's when you definitely need the counsel of other people. There's safety in a multitude of counsel. What do you mean safety on that? There's safety for your mind. There's safety because you don't want to lose your peace. You don't want to start getting sick. You don't want to go over the edge. If you have other responsibilities, such as other family members, you don't want to neglect them, right? So you have to find a way for you to be okay. And you being okay has to come from that safety. There's safety in a multitude of counselors. NAMI is a big organization. I'm a member of NAMI. It's great. A lot of the clinics have different organizations that you can try. Mental Health Association. There are a lot of them out there that you can just get information and learn from. This is not your fault. It's not uncommon for your loved one as well as you as a family member to go through this denial stage. The first couple of times it happens because you really don't believe it, right? I think he can do better or she can do better, and then it may take a couple of relapses for both of you to realize, okay, no, I do have an illness and this does have to be managed. The quicker you can get to the point and accept the illness, the diagnosis, accept the fact that your son, though as bright as he is, may not be able to go to Harvard this year or next year, okay? And that's a big thing for family members. We have so much parents. You have a lot of hope for your kids, and then when they become ill, you have to deal with the reality that they may not be what you thought they would be. They may not become the doctor that you want, or they may not, become the lawyer or whatever the case is. I always say that the quicker you can embrace the illness, understand how it impacts you, and understand your new normal, there's nothing that you can't do. You may have to move a little slower, may have to take another route, but you'll be surprised at what you can do. The hardest thing is getting people to accept the reality of the illness. That's the hardest thing. Unfortunately, that can take some time. Okay. You have to learn how to walk through it. You have to learn how to deal with it. You have to be able to tell the difference between your loved one and their personality. Your loved one has a personality. Having a severe mental illness has nothing to do also with their intellect. And they also have a personality. Sometimes they may say, no, I don't want to do something, and it has nothing to do with the illness. They just don't want to do it. So you have to be able to know, to tell the difference. And you have to understand how your loved one just functions differently. Right? And when you understand that your loved one functions differently, you have to learn how to do that. Just like if you had diabetes, or were diabetic, I've noticed that some people have to make sure that they have candy in their purse, right? Because their body chemicals change or whatever. Well, you may have to do something like that with your loved one. You have to make sure that help them with their medications or help them get the help that they need. But you don't need to smother them either, because at some point, the idea is for your loved one to embrace their illness, to understand their relapse signs and symptoms, and they do that many times by being around other people as well who have similar illnesses that they can bounce things off of, and to begin to manage themselves and begin to walk the road to recovery. Recovery doesn't mean that they don't have any symptoms. Recovery just means that you've learned to manage your symptoms, to deal with your symptoms, and you've developed a life in the midst of them, right? So again, there's a lot to this, a lot of different variables. But again, I wanted to just make sure that I kind of covered a lot of those different variables. It's so much. But the bottom line is you want to make sure that you get help. Let me give you this number, and I should know it by heart. I'm going to give you a couple of numbers. There's 1-800-273-8255, and that's the National Suicide Prevention Lifeline. You may say, well, my loved one is not suicidal, but you can call them as well, and they can connect you. Another number, and again, every state, let me say this, if you have a loved one with a severe persistent mental illness, you should, when they get out of the hospital or during the hospital, find out what the resources are in your area and post them to your refrigerator. Make sure everybody has them. If your state does have a crisis team, you want to have that. You might want to ask the doctor, okay, if this happens again, what's the best thing that I could do? Because they may have phone numbers that you could use. Right? You want to do that. Most clinics, if your loved one is associated with a clinic, they have an after-hour phone number that you can call, and that after-hour phone number can kind of walk you through. It may be, you pick it up, they may have a list of phone numbers you can call. It may be a person that you call, they'll call you back, or whatever the case is. Now, SAMHSA also has a national helpline, and this is the Treatment Referral Routing Service. And what this does, it provides 24-hour free and confidential treatment referral information. This is 1-800-662-4357, 1-800-662-HELP, H-E-L-P. This is the SAMHSA's National Helpline. I'll post this on it is on our website. But again, you want to have this. Put it on your wall, your refrigerator, so if you ever get in a crisis, you can call. But if your loved one is connected to a clinic, that you want to try to stay in touch with them. The more on top of it you are as a family member, sometimes the easier it is to get your loved one help when they need it, and help for yourself as well. Again, also as a family member, you may feel inadequate. You may feel like you're not doing a good job. The fact that you love your loved one and you want to help says that you're doing something right. No, it doesn't work all the time like textbook. The doctor or therapist may say, well, why don't you try this? And you may try it and it doesn't work. Don't get discouraged. Your loved one is naturally going to respond to a psychiatrist or a therapist, somebody different outside of the family, differently than they will respond to you. You may have to get creative. I know some family members, their loved one won't take their medication, they put it in their food. Some people may say, oh, I don't know about that, but it works. So sometimes you may have to think outside of the box to do certain things, right? It may not be quote unquote the thing to say, but it works. A lot of times people are worried about, I don't want to say the wrong thing. When you love someone and you're really trying to help them, that will come through, right? It will come through. So give yourself a break. Okay, this has been one. It's Getting Better All the Time Mental Health Outreach. Igbattmho.com. As a family member, don't beat yourself up if you've tried everything you can. So the system sometimes is just hard. It's just hard, depending on where you are, to get your loved one help. You may try, and the person, it just doesn't work. Meaning that we call the crisis team, we call the police, they may not take them, they come right back. You may, try to get a guardianship, and the guardianship doesn't work, and you get tired. You have to kind of take a break, but get back on it again. Get back up on the horse, but you don't have to do it alone. There are people out there that can help you, that have gone through what you're going through, have gone through the process, have know the resources in your area. If there are no resources in your area, they know where you can get help from, and it's just having someone to talk to. So again, I think you're doing a great job. Don't beat yourself up. It's Getting Better All the Time Mental Health Outreach. Sister A. Legree, IGBATT.com. God bless you, and good night. And I will talk to you again in a little bit.